this meeting is also live streamed on YouTube. So about the query, what Dr. Rawat, we had a chat in the evening about this link being shared with everyone. So the thing is that earlier what we used to give as a panelist link, now what others told me is that this link will be now kept for the faculty as well as the panelists, and the rest everything will be like live streamed on YouTube. So that is the reason why there is a slight change in the protocol now.
So they will not be able to ask questions?
They will be able to ask, but I think Dr. Kanaram will receive it on the chat box and then he will relay it. Because otherwise, if you keep it open, it will become slightly messy.
It is better to have chat box questions.
Yes, that's right.
We were able to manage session well.
So I think it's 9 p.m. So welcome everyone. On behalf of IIT National Respiratory Chapter, I welcome you all for the webinar on a very important topic which we all have in our country, tuberculosis. Today we are commemorating the World TB Day. I can't exactly call it a celebration, but then it's more of an eye-opener for all of us, because pediatric tuberculosis still is a very challenging problem in our country for several reasons. And though the government has planned from a control program to immunization program, we still are finding a lot of lacunae. So in order to discuss about the pediatric tuberculosis and its impact on the overall health pattern in India, we have illustrious speakers, invited faculties, and the one who have done, they have spent their decades of career in tuberculosis research and other things. We are privileged to have Dr. Parinder Singh sir. We have Professor Dr. Kamal Singhal, who is from Delhi. And we also have Dr. Sushant Mane, who is Associate Professor in JJ Group of Hospitals, Mumbai. And they all will enlighten us about various aspects of tuberculosis. And we are privileged to have Dr. Kanaram Jat, who is a Professor of Pediatrics at AIIMS, Delhi, and himself a learned scholar and researcher, and who also knows a lot of details about tuberculosis. So with this opening remarks, now I invite Dr. Kanaram Jat to take over. And there is a small change in the program. As we had shared in the flyer, Dr. Varinder Singh has to leave for another important meeting at 9:35. So he will be taking his talk first. So he will be speaking on the latest RNTCP guidelines. And thereafter, after that, Dr. Kamal Singhal will talk about a more important clinically relevant topic, that is radiological patterns in tuberculosis, pulmonary tuberculosis. And finally, we'll have newer diagnostics by Dr. Sushant Mane. So with this, I think Dr. Kanaram sir, I request you to take over and let us begin. You first introduce the speakers. I hope Dr. Varinder Singh will join us in a few minutes. So maybe you could start with the opening remarks about, you can talk about what is the present status of pediatric tuberculosis in India, what is the incidence, and let's have some opening discussion on that till sir joins.
Sure, sir. So thank you, sir, for giving the opportunity to moderate these important sessions. So although Government of India planned to limit the TB by 225, but it was not achieved because of you already mentioned there are many challenges. And same is true for the pediatric also. So in today's sessions, we have the three speakers. First is the Professor Varinder Singh. He is currently at Hamdard Institute of Medical Sciences and Research, and he is former director professor at Klavdi Saran General Hospital, Radiological Medical College. So sir will speak about the latest NTEP guidelines regarding pediatric tuberculosis. Next is the Professor Kamal Kumar Singhal. He is Professor of Pediatrics at Klavdi Saran General Hospital, Radiological Medical College, New Delhi. And finally, we have Dr. Sushant Mane. He is Associate Professor at JJ Group of Hospitals, Mumbai. So all three speakers are well-known personality in the tuberculosis, and hope we will get some very good benefit from them. So to start in the pediatric tuberculosis, although very much different from this, so I think we need different approach in the pediatric tuberculosis. So till the sir joins, can I ask the opening remark?
Yes, yes. Please, please.
Sushant Mane.
Let them share the slides. You just check them. Anyone we can check that. Dr. Kamal and Sushant can share this.
You can check this, Dr. Kamal, you can
Mr.
check
Jan.
sharing.
Sir has joined.
Sir has joined.
Sir has joined? Okay, great. Wonderful.
Good evening.
Good
My
evening, sir.
apologies for being late.
No, sir, no, sir. You are most welcome.
Sir, we are just starting the session.
Thank you very much for joining in, Dr. Varinder, sir, and Dr. Kanaram, to kindly introduce Varinder, sir, and we request you to start with the session.
So, welcome to Professor Varinder Singh, sir. So, sir is currently professor at pediatrics at Hamdard Institute of Medical Science and Research, and sir as a former director professor at Kalapati Saran Children's Hospital, Radiological Medical College, sir. So, sir will discuss regarding this latest NTP guidelines regarding the pediatric tuberculosis. So, may I request Varinder Singh, sir, to start the session.
Thank you very much. Thank you, Dr. Jan, Dr. Bafna, Dr. Rawat, for inviting me today to talk on the recent update in guidelines of managing TB on this World TB Day in 2026. So it's a plan of my talk. I think whenever we say recent for anything,
Sir,
we
your
expect.
video is off, sir.
Sorry?
Sorry?
Your video is off.
Sir,
Yeah,
your
my
video
video
is off.
The slides are moving?
Yeah,
Slides
slides
are
are moving, sir.
Yes, sir, slides are
Yeah,
moving.
I don't want to put on my video because I have a limited bandwidth. I'm standing by a roadside to take this talk. So bear with me if you have some disturbances. I was traveling somewhere, then it got delayed on the way. Never mind. So we whenever we talk of recent guidelines or recent guidance, we expect something new. I think the major change in NTP at current time is this related to strategy of identifying new patients, the 100-day campaign, and some change in therapy or newer therapies which have limited impact on pediatrics. So what is it which is there no change? No, there is talk of newer samples, there is some maturity about how to use the NTP guidelines for a clinician who may or may not send these patients for NTP, but then there are NTP approved IAP NTP guidelines. So the IAP has joined force with NTP, therefore these guidelines are common to public and private sector. So we will talk about what is the current status of the newer diagnostics which have been provided by the NTP. I am not going to talk of novel diagnostics otherwise because I know there is another speaker who is going to speak on it. And I'll briefly talk of update on newer regimens because in 25 minutes I have, it will not be possible to cover everything. And anyway, most of the impetus is on diagnosis. So one thing which happened in last decade was the disruption of the usual paradigm of diagnosis by the molecular tools and technology. While this has come, we just have picked up some terms like expert, CB-NAT. But this is beyond just a simple molecular test, and we have, with usage, also understood its limitation maybe. We have also understood that there are certain questions on how it should or should not be used. And that's what I want to highlight in today, the molecular test under NTP. So the molecular tests which are available under NTP are the common is CB-NAT, which is the euphemistic presentation for expert MTB RIF, which is made by Cepheid USA. It's an imported product. It's a self-contained unit, so it's lab in itself. The moment you put in a cartridge, it's a self-contained closed system. Then we have TrueNAT, which is an equivalent of the same, made in India by MolBio. So it's made in India. That with current time when the supply lines are affected, when some political disposition can decide what to share with another country or not, it is important to have an in-house test. We have an in-house test, which is chip-based. It is like expert, but not exactly like expert, and I will explain that in a little bit. The third thing which we talk of in the context of NTP is LPA, first line and second line. which is also a molecular test, but not a rapid molecular test. It's a semi-rapid molecular test. While the first two tests can give you answer once you put in a sample in about 1.5 hours to 2 hours, this will take about 3 days. Then is this new, player in the field, which is from my lab, again an Indian company called PathoDetect, which is a real-time PCR with two R and H. This is not as yet approved by WHO, and ICMR has evaluated it, and now the program is going to evaluate it. And program now is also pushing open PCR kits. Why? Because now there are kits available which are not, the PCR probes which are available, and kits available which can be used with several different molecular diagnostic machines, which the country bought during COVID. So the idea is to expand it using open source PCRs, because TrueNet is again a TrueNet cartridge will work only with TrueNet. Expert cartridge will work only with Expert. While these open PCR kits can be used with several other platforms, not with these two platforms. So the machines which support open kits can be used. So that is to maximize the reach of diagnosis to the periphery. That's the programmatic function. So what is each of these tests? Gene Expert, the commonest which we are familiar with. Gene Expert is just a platform. The real name is MTB RIF assay, because Gene Expert could do staph, it could do carbapenem resistance in any things. So Gene Expert is a molecular platform. When we use it for MTB and rifampicin as a nested test, that means you don't have to test this twice. Then once you put in a sample, it will test simultaneously for MTB and RIF resistance, and it results indicate therefore MTB was detected or not detected. If detected, it gives a semi-quantitative result as high, moderate, low, or very low. And then it also tells you whether resistance to rifampicin was detected or not detected, or the DNA copies were not enough, and therefore the results are indeterminate. Indeterminate is not same as intermediate resistance, which we see in pyogenic. So indeterminate means machine doesn't know what it is, right? Now, limit of detection is 120 colony-form units. So this is a big leap. Earlier, our diagnosis was smear-based, which was 10,000 bacilli per ml. Here it is 120, so a big leap. But yet, a lot of paucibacillary specimen may have, particularly extrapulmonary, may have even less than 100 DNA copies. And therefore, even this test can come negative in about 40-50% of patients with TB. Therefore, this is a good test to say there is TB. But if it is negative, you cannot say it is not TB. So three things. One, it is a rapid test, less than 2 hours. Limit of detection 120. Semi-quantitative will give you both MTB and RIF resistance. The moment it is MTB very low and RIF resistance is detected without a risk factor for RIF resistance, so it's a new case who is not been exposed to an MDR, and you get RIF resistance with very low, then you must retest it, because this may be a false positive. Otherwise, the specificity to resistance to rifampicin is very high, to the tune of 90%. Sensitivity for pediatric sample is low, but specificity, once you say it is MTB, more than 90% specific. Once you say it is RIF resistance, apart from very low, sensitivity specificity is very high. Let's go to the second test, which is TrueNat. This is an Indian test, again 1 to 2 hours, portable, but it is chip-based. So it's a sequential test. That means first on the chip, you will test whether MTB positive or not. In the samples where you detect MTB, then you use another chip for RIF resistance, only in those where you find. So it is a semi-open test. It's not a totally closed test. Closed tests are at a lesser risk of contamination. Here, DNA amplification is done separately. So that's a slight difference from the expert. However, if somebody has come positive on TrueNat, you don't have to reconfirm it on expert or vice versa. They are equipoised. They are used one against the other. There are modifications to both expert and TrueNat. I will quickly take you through one modification of TrueNat, which is TrueNat MTB Plus. I'm going quickly through this because this as yet is not fully approved by the program or by WHO is still under evaluation. It is called TrueNet MTB Plus, and this has a limit of detection of about 25 DNA copies, just like Expert Ultra, about which we'll talk little later. So both Expert and TrueNet first generation now has a newer generation models, Expert Ultra, which is now several years. Indian program is the only country in the world which uses Expert cartridge. Everywhere else, Expert Ultra has replaced Expert in almost every country and outside of the program also. Apologize for this interruption. Okay. Now, Expert Ultra, as I said, is an automated molecular diagnostic test, and it detects RIF resistance in patients. I will have to take this call because this is my host, but let him call once more. So my apologies again. Expert Ultra provides uh, uh, a lower limit of detection of 25 CFUs. So therefore, it is better in detecting. एक मिनट में उसको मैसेज कर रहा हूँ भाई, इतनी देर तक मेरे से माफी कर दें. Okay.
Yeah.
So when you increase the sensitivity with ultra, what is the cost? The cost is that it brings out a new category of semi-quantitative, which is called trace. So we had up to very low with expert. This brings trace. Once you have trace, then RIF resistance diagnosis is often not given by the machine. So you only get MTB, you do not get to know about RIF resistance. And in a new patient, a trace result also needs to be reconfirmed because the specificity may go down. In a patient with risk for DR, you will accept it. The third thing is even the specificity for MTB diagnosis and trace calls goes down a little bit. Now, one could even argue this as against ultra, or one could argue that our clinical diagnosis is much more less sense specific than maybe some overreach by trace. That's for something which we can just continue to argue. As of now, the program took a call that this distinction may be difficult, so the program has not taken up ultra. While all the expert tests you send outside of the program in private sector is giving you actually an ultra report, which you are not caring to note. There are no cartridges, non-ultra cartridges available outside. Remember, none of these tests can differentiate between live and dead bacilli. So that means if a MTB comes positive in a treated patient, it may be a dead DNA which you are recognizing and not necessarily an active case. If you want to identify an active case for definite, then you need a culture. And now we have liquid culture, automated rapid liquid culture systems called BECTEC, on which you can also do phenotypic drug susceptibility. It uses a fluorochrome, which when oxygen quenched, changes its fluorescence, and therefore earlier was radioactive, but this system is a fluorochrome, which change of color tells you that, okay, here is a tube which is showing positive growth, which can be then checked whether this growth is because of contaminant or MTB, and then if MTB, whether sensitive or not. So that's how we use PECTEC. So effectively, the first line test, expert MTB RIF or TrueNet, about 120, 130 coloniform unit. MTB Ultra or the TrueNet Plus, which will come, is 16 or 25 CFU per ml. So the 25 is average, 65 is the minimum it can do. Likewise, 131 is the average, 125 is the least, 121 is the least it can do. When it comes to culture, it's between 10 to 100. So culture is used to identify the specificity of the new test. And therefore, we must realize that our gold standard itself is not going to be positive in a lot of extrapulmonary cases which have less than 100 coloniform unit. So the yield from culture is about 70% with a single sample. while from expert is about 85%. This is one of the studies. Line probe, which is another molecular test. This is a molecular test, but is very different. One, it is a semi-rapid, so it's 72 hours. Secondly, its limit of detection is 10,000. That means similar to a smear positive. That means this will not work in a non-smear positive specimen. That is why only smear positive tests are sent for line probe assay, which means effectively this will get restricted to only our adolescent children and not young children to use. Okay. It is primarily used for diagnosis of drug resistance of TB because you have two types, type 1 and type first line and second line. It is highly sensitive and specific, and therefore can be used in a pediatric case once you have an isolate on culture and you want to rapidly, you don't want to wait another few weeks to get a phenotypic drug resistance. Then on culture, you have millions of bacilli. So the limit is not there. So from a possibacillary specimen, you get a culture. Culture has large number of bacteria. You apply a line probe assay, and within 72 hours, you would know whether this culture is harboring resistance to rifampicin or not, or INS2 not on first line. And if it is resistant to any of these, then you can put it to second line to know, because whether it is INS resistance or rifampicin resistance, your next key drug is fluoroquinolone. So then you run second line to know whether it's fluoroquinol sensitive or resistant, to then decide which regimen your patient will go on. So now we are understanding the hierarchy of tests which is available to us. Earlier we were just at random saying, "Acha, line probe wahan bhej denge." This is the maturity under the program, that there is a more flow. There is understanding within the labs. Many of the time, if you will send such a specimen to the lab, they will automatically, the lab will send from first line to second line if they will see a rifampicin or INS resistance, because that's what they're expected to do. That's their protocol. We also have for second line an rapid test called Expert XDR. This was going to be adopted by the program. Since it requires different type of CBNAT machines, this is not as yet become very functional, but program has somewhat accepted it. So this has a limit of detection, same as Expert and not as Ultra, which is about 120. But it can tell you about INH and fluoroquinolone and ethinomide, which is shared by resistance with isoniazide, and also amikacin. Amikacin now are less. Tests came up when they formed an important part of armamentarium before delamine or bedaquiline came, or our understanding about linezolid came. So therefore, this remains as a legacy, but much less usage. But your larger usage is about fluoroquinolone. So Expert XDR, because its limit of detection is low. So if you are not able to you can't wait for a culture and then an LPA, then a specimen outside of the program can be tested by this test, which is approved by WHO and has also been evaluated by the national program. And the reservation the national program has is that while WHO says INH's specificity resistance is about 90%, when Indian country review was done, then results were relatively poor, about 70% concordance between phenotypic sensitivity and expert XDR with Indian type of mutation was found. So that is one of the reasons there has been a slight reservation by the programming accepting XDR. But it's approved by the drug controller, and some of the labs are also using it, and it may gradually get incorporated into the program. So this is at the cusp, not something which is available under the program immediately, but there's something which is very useful, because instead of using LPA second line on a culture, it may give you a rapid XDR. Sometimes when there is a child not improving, you're not only worried about RIF resistance, you are also worried about INH resistance, and this will give you an answer when your expert says RIF sensitive. You can do an expert XDR to know whether it is INH resistant or not if your patient is not responding and you're still working around trying to find a first line resistance. Okay. As I said, PathoDetect is something which is approved by ICMR. NTEP does not approve. NTEP is trying to adopt it. It is made in India. ICMR field trials are over. It's a huge machine, so would be at a district level. Limit of detection is again 120. but it will give you both R and H. So that's an advantage. So 120 coliform unit limit of detection, but you will get both R and H. So possibly in future, we may be seeing more use of this machine called PathoDetect. This is coming up. Some private labs have also taken up, and program is also evaluating it in some of their sites. It is not countrywide available as yet. So this is the plethora of tests which are available to us. But are there any further limitations? The biggest limitation which these tests have when it comes to its recommendation for pediatrics is pediatrics samples are not necessarily sputum based. And we often look for a sputum based diagnosis, while our samples may be a stool or oral swab, where then you have to find which will work best. So if you are using stool, then one stool sample will need further processing. Otherwise, the yield of stool is reported between 30 to 70% of those who are positive on a respiratory specimen. Actually, a study from Bangladesh showed much lesser sensitivity. So this is variable. Bangladesh has used expert ultra and not expert. And if I send stool as a specimen because it's easy to collect, it will come negative in a larger. If it comes positive, fine. If it comes negative, you don't have a choice. You'll have to go for a respiratory specimen if it is a respiratory pulmonary case. So this may be useful in far-flung areas, some family who's just not willing to get, but this adds burden to, of course, to the program or to the individual because if the sensitivity is low, but it remains one possibility is this tool being used. So largely, as I said, ultra is something which is being used. Accuracy of ultra compared to culture in EPT sample is again 100%. But as I said, problem with EPTV sample or other samples with ultra is it's an off-label use. Company never recommends it. And when you use it, the specificity ranges from 70 to 90%. That means some of, जैसे आपने, suppose there is a patient you did a ball or you got a pus from joint, and you are not entertaining a possibility of TB, but you say, यार सारे करा दो. And you do get an expert ultra run and it comes positive, trace positive, then you may get into trouble because trace has come positive. You to negate a molecular positive trace requires a lot of courage. But remember, the specificity is now about 70%. It's not 90%. So that is one caveat which one has to. We burnt our fingers with ball specimens. Initially, सब भेज दो. And suddenly you get positive. यार बच्चा ठीक हो गया. ये तो दूर दराज से टीबी लगता नहीं है. But ultra has come positive. So as I said, it's a very good test. I am not saying it is a bad test. But if your pre-test probability is not there, then it can mislead you if the reading is traced. So that's the caveat which you must remember. Okay. Urine lamp is something which is recommended for HIV co-infected. So this is an antigen-based or basically a component of the MTB cell wall which you detect, and it is something which is as yet recommended only for HIV co-infected. Fujilam is the company which is making. WHO and also talked a lot about clinical algorithm. Program has still not adopted it, and we are glad they have not, because if you use these algorithms, your specificity of diagnosis of clinical radiological diagnosis suffers huge. Dr. Kamal has recently got a study done by one of his students, and I'm sure he's going to talk about it in his talk. The specificity was way low, about 30% with these. So I would not recommend. So quickly taking you through one case, user case, to see how one can use these tests. So this is a female child who initially had, 18 months back had bilateral swelling, some constitutional symptoms, and in Sikkim was diagnosed to have TB, no basis. Child had abdominal distension, and which showed gross ascites and some signs of persistent obstruction, partial obstruction. So comes to Delhi, in Delhi undergoes an exploratory laparotomy, and you see all these tubercles which are there and active TB. So very vague presentation, but this is what they work up for everything. MTB neither detected on culture nor by molecular methods. But histopathology says tuberculosis, they put on treatment. Some worsening of symptoms after 5 weeks. with because of intestinal obstruction. Again, conservative therapy, ATT completed in 6 months. Child is doing well. Then, after remaining well for 3 months, she gets symptoms again: abdominal pain, distension, fever, vomiting, easy fatiguability. They try some local treatment, doesn't work. They again land up in Delhi, and there is a deterioration with the radiological evidence of intestinal obstruction. So they come back to Delhi. This is the child's presentation at that time: dilated loops and dilate. CT scan shows fixed dilated loops, which are large. Now, surgical team has certain questions. What are those questions? Whether it is a relapse of TB, is it failure because he had some initial or acquired resistance, or it's a pure mechanical obstruction? All three are possible. So they do a laparotomy to see whether there is a band or not. They still find active tubercle. Now is the question, this is a treated case. What tests to send? So what did we do? What were our questions? Diagnosis of TB, confirmed histopathological, but not complete because we did not know the resistance to begin with. Treatment taken correctly? Yes, taken. Drug tolerance? Yes, adherence was good. Could it be complication due to sequelae or fibrotic band? Yes, could be. Could it be to relapse? Yes. But per operative, we have seen active tubercle, so it looks more like relapse. Drug sensitive or drug resistance, you can't see AFB with naked eye. And even if you see AFB, it doesn't tell you it is sensitive or resistant. So that is where we were. So what can you do? Send a gene expert ultra. It shows Mycobacterium tuberculosis sensitive to rifampicin. So tells you one thing, that there is RIF sensitivity. XDR, no INH resistance. Great. So I do not have resistance to first two. But one question which is still not answered is, are these dead bacilli or alive? Here I am seeing tubercle. I may say they're alive. But many times you do not have that visual impression available to you. What do you do in that situation? So you have no choice. You have to send an MGIT culture, because this will come false positive also. And from MJIT, one can use line probe or an expert XDR to know further resistance. Okay. So this is what we did in this child. And we found we could restart the therapy. This child is coming back to me in the coming week after 9 months of second course of first line therapy, doing absolutely well. She's going to school. She's fine. Now, a word about MTB detection in CBNAT after treatment. How long does it remain? So these are studies from adults. A very important slide. I quickly would explain it to you. The purple thing is CBNAT positivity, and the smear microscopy is the blue thing. So by the time you are 2 weeks into therapy, nearly 70-80% of the smear negative positive will become negative. Whereas only 20 but 30% of the CBNAT will become negative. That means you cannot use CBNAT positivity as a marker of activity while on treatment. What happens after treatment? Even after treatment, nearly 6% of the patients, till a median of 11 months, came positive. So you have a risk of MTB coming positive even in a healed patient. So therefore, of all the armamentarium which is available under NTP, the better understanding is now how to use this test sequentially to deal with the given clinical problem. So I have used a clinical use case. First, I have given you the theoretical background, what all is available. And now with this case, I have tried to explain to you how it can possibly be used. I know I'm running out of time. I'll just quickly take you one slide on what is new in the management. So there is something about 4-month regimen for DS minimal TB, which has not been accepted by the program. This is SHINE trial, simply because how to say it is limited TB, otherwise a good evidence which is there. Short intensified regimen for DS TBM, 6 months with ethinomide, again not adopted by us. We recently concluded another trial on 6 months ATT for TBM with high dose rifampicin of 30 milligram per kg and using levoflox instead of ethambutol. Again, not better, higher side effects. Short regimen for DSTB except severe EB, which is available for children above 12 years, adolescents, is going to come up because it says rifampicin with moxifloxacin. So it is HPMZ, INH, rifampicin, moxifloxacin, pyrazinamide, followed by HPM for total of 17 weeks. So this is a 4-month therapy, not same as SHINE trial, which is coming for DSTP other than severe EPTB So any form of pulmonary, unlike shine, which is small, the non-severe pulmonary TB, which is where the problem is how to identify that. So this may be coming, but this will come for your adolescents, not for young children. Now there is also a talk of similarly for adolescents, BPAL M regimen, which has pretonamide. Pretonamide has a difficulty that it cannot be used in below 12 years of age. It is not recommended. Bedaquiline, so far we do not have recommendation to use below 5 years. So that's another limitation in our country. Worldwide, they're using for all ages. In our country, the DGCI has not given approval below 5 years. So this regimen, BPAL M, is only for adolescent. These are the newer changes which has come in the program, adapted by the program, but available only partly to some of children. Therefore, I have not alluded much to them. In the preventive therapy, now we have a new regimen, 12 weekly dose regimen with rifampicin and INH. Sorry. So once a week dose, 3 doses. You also now have in the market a new TB skin test, which is not tuberculin, but antigens within tuberculin like ESET6 and recombinant CFP10, again made by Serum Institute and my lab, and it's called SciTB. Positive is 5 millimeter. For INH resistance, now we also have 4R, and for fluoroquine sensitive MDR 6LF, levofloxacin. So this is all which is new, and what we understand how to use the new. So that's the new thing. Thank you.
Thank you, sir, for explaining talk. So can we have few questions?
Yeah,
So,
please.
one question is by Rawat sir. Are private labs in India or NTEP program accepting stool samples for testing?
I am not aware of the private labs, but program under certain programmatic areas where they are looking at will accept stool.
Okay. So are there no questions in the chat box? So I can ask the one question. Because you
Can I-
mentioned when the expert is very low or ultra stress, so we should repeat the test. So it is seen.
If there are no risk factors for drug resistance.
Yeah, sir. Sir, but when we repeat, it's frequently negative. So how many times we should repeat that to conclude is positive or negative?
Yeah, that's a very good question. I didn't have time to go. So there is an algorithm for that. If your repeat test is negative, either you repeat another time, or if there are no risk factors, drug sensitive TB is commoner than drug resistance, you treat as drug sensitive. Unless until the repeat sample confirms RIF resistance against, you do not treat it as RIF resistance. That is the WHO guidance, that is the program guidance.
Sir, can I ask a question if you have time?
Yes, sir. Yeah. मैं आपके साथ हूँ.
नहीं, actually ये plan मैंने किया था because actually you were going to give the last talk, so I was going to ask a few questions related to what is the current status
क्या
of.
बताऊँ, घर परिवार भी चलाना है ना.
नहीं सर, बिल्कुल सही है. नहीं, मैं ये कह रहा था कि for a common pediatrician, I mean, like, where are we at this point of time as regards the tuberculosis control and our country? In what stage we are? Are we in the process of elimination? What are the shortfalls? What are the realistic goals? I just wanted to know on this issue. You are a part of the program, very important person.
I will draw parallel with one public health program success, which is polio. We thought we will send it out in 3 years. We took 12, but ultimately we threw it out. So if you look at indices, we wanted to do it by 25. Till 26, we are still struggling. So are we close to elimination? No. Can we reach there? Yes. Have we made any progress? Certainly. The mortality due to TB, the incidence rate has declined maximum in last 3 years compared to ever in the past. So there is a change. Has it reached the desired level of decrement? No, it has not. So we have not reached as fast as we wanted to, but there is some progress and it is still a lot of work to do. But जब हम करेंगे तो हम कामयाब भी होंगे.
Yeah. I would like to ask if other panelists are interested in asking questions to Dr. Varinder sir. He wants to leave. If there are no questions, thank you very much, sir, for sparing time. I know you had a very busy day, and thank you very much for enlightening us. And if there are any questions in the chat box, we'll directly send it to your mail, and kindly reply to them.
Thank you so much. And thank you for
Thank
being
you,
so
sir.
accommodative. Thank you.
Thank you, sir. Thank you. It was a pleasure. Thank you, sir.
Thank you, sir.
Best wishes to the meeting. Rest of the meeting. Best wishes.
Yeah, thank you, sir. Dr. Kanaram, I request you to continue with the further program.
Sure, sir. So after the excellent talk by Professor Virender Singh, now I invite Professor Kamal Singhal from the Lady Hardinge Medical College to talk on this radiological patterns in pulmonary TB in pediatrics. So Dr. Kamal, please.
Thank you, Dr. Kanaram, and thank you, Dr. Joshi, and the office bearers, EAP and RC, for giving me this opportunity. I hope the slide is visible.
Make slides visible.
Full screen. Make it full screen.
It's visible, and I'm audible.
Yeah.
I will request the participants to keep your fingers on the keyboard. If I'll be asking some questions, you simply have to type Y or N, yes or no. I'll try to keep it that simple. So from that, we will try and make out how many of you are still aware and awake with me. So radiology of pulmonary tuberculosis. We know pediatric TB is a possibacillary disease. So diagnosis in pediatric TB has always been challenging. And because we are left fumbling with microbiology at times, it is the radiology which comes to our rescue. And it helps us in many ways. It helps us in diagnosis of TB per se. And then when you have diagnosed somebody as pulmonary tuberculosis, it helps you in monitoring response to antitubercular therapy. And given this possibacillary nature, radiology becomes important, especially in pediatrics, and not just radiology, appropriate reading of radiology. So through these next few slides, I'm going to take you through what you expect in TB radiology and what are the fine nuances that are there. So if you look at if you look at pulmonary tuberculosis, the lung parenchymal lesion. So a very important or a very interesting thing about TB is that when you see a parenchymal lesion in any other infection, you will see a large parenchymal lesion, but no lymph node. But in pulmonary tuberculosis, the important thing is that you will see a very small parenchymal lesion, or at times not visible at all because of exposure issues, but a big lymph node. So this is how pulmonary TB differs from any other kind of pneumonia or infection, that here the lymph node is bigger than the parenchymal lesion itself. Now this combination of lymph node, and I'll just put one slide here just to show lymph nodes. You see what you I hope the pointer is visible.
Yes, Dr. Kamal, it is visible.
It's visible. Perfect. So if you see, this is the parenchymal lesion, but you see this is the big lymph node. So this is what is different in pulmonary tuberculosis compared to any other kind of pneumonia. And when you see this combination of a parenchymal lesion and a lymph node, it is called Ghone's complex. So the hilar lymph node, the parenchymal lesion is called as the Ghone's focus, and the combination of this with the lymph node is called Ghone's complex. Now this combination of lymph node and parenchyma may progress and lead to progressive primary disease, or it may just, as I would say, get contained, naturally heal on its own, or get treated with drugs, and later on it can present as reactivation. So natural healing in TB is known. You know, there were times the drugs were invented very late, discovered very late. So prior to that, it's not that all patients would die. Some of them would naturally heal. So the lesion can get contained on its own because of natural healing, but there is always a risk that it can have a reactivation. So this is the lesion that I've just shown you. This is a lymph node here and a parenchymal lesion here, a combination, which is known as the primary disease. Sometimes we just miss out on this parenchymal lesion. So this is the right hilar paratracheal lymph node, and this is the right middle zone infiltrates here. So primary disease is common in young children, although it can occur in any age group. Teens, almost 10% of them can have a radiological primary disease. The Ghone's focus usually occurs in the subpleural alveolar space, It's a small hazy kind of a solid ill-defined opacity, and sometimes it may resolve undetected and can remain dormant as LTBI. And sometimes they are so short-lived that at times you may completely miss them altogether, or they may be hidden only with mild pleural reaction. So at times all this may be very, very innocuous. So at times it can be very difficult to detect radiologically if suppose the film is a bit overexposed. More commonly on the right side, there is a theory behind it that the right lung opacities drain in the right lymph node, but the left lung opacity drains bilaterally. So you will have a mediastinal lymph node more on the right side than left side. Now let's talk about a progressive primary. Progressive primary means that this has gone beyond what we just saw. So the lymph node that we just saw, it can cause a compression of the airway. The lymph node will be around an airway. What it can do is it can be pressing onto the airway. And depending on how much it is pressing, it can cause obstruction, complete obstruction, and which will result a collapse distal to that. So a lymph node can come to you as a collapse of the airway because the lymph node has completely obstructed the airway. If the obstruction is partial, which means it's a bell valve kind of an obstruction, it can result in hyperinflation. So TB can present as a hyperinflation also because the lymph node has partially blocked it. And similarly, there could be that the lymph node will rupture into the airway. In that scenario, it will result in intrabronchial spread and you will have a parenchymal lesion. So, which is called a bronchopneumonic consolidation, and it can cavitate. The Ghon's focus, on the other hand, can result in a contiguous rupture, pleural effusion, pericardial effusion, miliary TB. So let us go through this. What is the proportion of patients? What kind of patients will ultimately have a progressive primary? So primary means there was a parenchymal lesion in the lymph node and healed not on its own. But in some cases, it will progress. For example, and the risk of progression depends on host factors. In very young children, there is a higher risk of progression to progressive primary or a more severe disease. In age groups less than 5 years and teenagers, also there is a high risk of progression. And if suppose the immunity is down, even then there is a high risk that there will be a progressive primary disease. So we all would encounter or would have experienced, almost 1/3 of us are exposed or we have faced the TB bacteria, but not all of us go on to develop all this. So it's a combination of our immunity and the bacterial load or the bacterial virulence. And of course, the age is a very important factor. If you look at this lymph node, this chest X-ray, this is a 13-year-old. All of them are presumptive TB, came as presumptive TB and later proved to be TB, and they responded well to. So these are not, most of them are not off-the-run cases. They were all proven TBs. So in this case, if you see, this is, I hope the marker is visible here. This thing jutting out from the mediastinum is what tells you that this is a lymph node. And why do I say lymph node? Because, so the base is all mixing up with the mediastinum, which tells you that there is a mediastinal lesion coming out. So this lymphadenopathy is something which we call highly suggestive of highly suggestive of TB. So there are 3 radiological findings. Again, this is another kind of a lymph node. Here, what you see is that compared to the previous one, here, the lymph node is slightly higher up. In that case, it was in the hilar region on the right side. In this case, it is the paratracheal region. This is a 3-year-old male child with a paratracheal lymphadenopathy. So this is a lymph node here. Now, let us look at this. This is another kind of a lymph node where you can actually see the lymph node, and very beautifully you can see the right main bronchus and the right upper lobe bronchus also. And this is a lymph node. So lymph nodes are highly suggestive of TB in a given scenario. Now, it does not mean, can somebody write in the chat box, what radiological findings are confirmatory of tuberculosis? Use your chat box. Let us see. Anybody who gives a correct answer, we will clap for him at least. If somebody is there. So what are the radiological findings on which are confirmatory of TB? So I'll proceed ahead till then by the time we get it. So this is a child who presented to us like any other child around 3 month old, cough, coryza, respiratory distress, and the resident says, okay, this child is, we are treating as bronchiolitis. But there was something very off or odd in this radiology. If you look carefully, this is this side is more black compared to this side. You see there is a bit of this side is more hyperinflated also, the left side, compared to the right side. And if you look very, very closely, what you will find is that the left main bronchus hair is narrowed. Within this arrow, if you see, there was narrowed. And this was causing some kind of a bowel well obstruction. So the left-sided lung was much more hyperinflated compared to the right-sided. And if you look very closely, the heart was shifted to this side, to the right side. And if some, you could make out there is a big lymph node mass over here which was pressing the, these were the days when we did not have CB0. This child had an AFB positive on induced sputum at that time. So this was the lymph node which was causing a bowel well obstruction. I just said if a little bit more obstruction and you will have a complete collapse on this side. In this case, this is hyperinflation. Okay, this is the child who came to us with complaints of 15-year-old, 1 month history of loss of appetite, loosening of clothes, lethargy, low-grade fever, and a left-sided swelling on the left side of the neck. And on this radiograph itself, if you can see here, in the soft tissue, you can make out there is a swelling over here. So lymph nodes, chest X-rays can show a lot of things, which if you are careful enough. And when we looked carefully, we saw that so this is an indentation on the trachea. So a lot of things that you would will see on CT, if you have a good eye, you will pick up on X-ray also. Like in this particular radiograph, this is the child who had a swelling over here, and on the chest radiograph, we found that there is a compression of the trachea also. We drained this swelling and the compression was actually also gone. So intrathoracic lymphadenopathy is highly suggestive. So we are taught that lymphadenopathy, miliary picture, and a chronic fibrocavitary lesion are highly suggestive of TB. Radiology is not confirmatory. It is never confirmatory. It can suggest, highly suggest, but confirmation only comes through microbiology. So intrathoracic lymphadenopathy can have different explanations, like malignancy, like lymphoma and all. So one has to look at overall clinical picture, and radiology should not be seen in isolation. It's a commonest radiographic finding, this intrathoracic lymphadenopathy, and represents a local inflammatory response following a pulmonary infection. And unilateral lymph nodes are much more common in TB compared to bilateral lymphadenopathy. On a plain radiograph, as we had just seen, it is seen as a lobulated density with a lateral well-defined margin. And sometimes you may have to, they may not be well seen on a frontal film, which means an AP or lateral film, AP or a PA film. But they may be better seen on lateral film. I'll show you an example how they are seen on a lateral film, and should be differentiated from pulmonary vessels. In young infants, a thymus can mimic a lymph node. So to say whether it is a lymph node, you have to look at corroborative evidence. Thymus is a soft structure. It doesn't push or pull. If normal thymus is, if the thymus is pushing or pulling structures around, it is more likely to be something like thymoma rather than thymus itself. In this case, we have a mediastinal widening. The corroborative evidence that there is a significant lymphadenopathy here is, if you look at, I don't know whether it is projecting well to your side or not, this is the trachea, this is the left main bronchus, and this is the right main bronchus. This is the angle between the left main bronchus and the right main bronchus. If this angle is more than 90 degrees, it tells you that there is something big over here, which is causing it to split up. So this was the subcarinal angle in this case, more than 90 degrees. It's an evidence that there is a big lymph node over there. Otherwise, we had lymph nodes bilaterally, and you have some right paracardiac non-homogeneous opacity. So this is the lateral X-ray, where you see this rounded structure. This has a fancy name also called the donut sign. So laterally, if you see here, this is the donut sign. In a lateral X-ray, this is the vertebral column. This is the sternum. And this is where the heart would lie. This area behind the sternum and this area behind the heart are black. If you find something here, then something is wrong. And this is the area where you will have a lymph node, if at all. It will be seen here like this as a, this is an abnormal X-ray which is showing this donut sign. Okay. This is a 3-month-old child with 1 week history of cough, coryza distress, bilateral bronchi, no history of TB contact, HIV negative. Your opinion? Anybody wants to write it? So I think the audience is probably not able to contribute well in the, there is some problem here. They are not able to write.
Yes, sir.
Fine.
No comments from the audience here till now. So we are not sure that they are able to put
I don't know. I think they do not have access to this chat box. Otherwise, somebody would have written something. Fine, doesn't matter. So this is the big lymph node over here, and it looks like a lymph node. But if you look at the extent, it is so big with a lateral margin over here. We thought that it is a thymus. The best way to confirm it is get an ultrasound done, and does not have radiology, radiation exposure, and thymus in a way can confirm that this is ultrasound can confirm that this is a thymus. So this, in this particular child, we also had a CT available, of course done by somebody, by some other health facility. Why the child came to us. So this was a thymus which can mimic a lymph node. So look at the child holistically, not in this picture. 10-year-old child, cough for 2 months, no fever, weight loss, and no TB contact. Now, in the absence of the chat box answer, it is so difficult to throw up. Okay. So this is the child who had a 2-month history of cough, but no fever, no weight loss, no TB contact, 10-year-olds. So this structure is what a lymph node would look like. But you know, this was a ganglioneuroma. So I'm just trying to tell you that if you find a structure like this, very likely in our country, epidemiologically, that will be TB. But keep your things in mind that this could be something like ganglioneuroma, something called like a bronchial bronchogenic cyst. All those things can also appear. But in this particular child, see, there was no fever, weight loss, or decreased appetite. So keep review the child holistically. And this was a ganglioneuroma. This is a child, a 13-year-old boy, microbiologically proven TB. ATT he had received for 1.5 months. There was weight gain. The child was afebrile now, but the cough was present and the breathing difficulty was present. And he had a brassy kind of a cough. And that is what the child was sent to us. So after 1 month of treatment, the constitutional symptoms are responding. The fever is gone. The appetite is good. But you see this big patch which was not responding. And if you look closely on this radiograph, if you look at the trachea here, this trachea at this point looks narrowed. And we thought probably there is a lymph node which is pressing this trachea and which is causing the compression here, and because of which there is a right upper lobe collapse. So at times when you say the child is not responding, it is not that the disease is not responding. It is just that there is some kind of a mechanical obstruction which is not, because of which the symptoms are persisting. It does not mean a TB which is not treated. In this particular case, the close-up of the X-ray will show you that the trachea is tapering like this. And if you look at the CT, you can see this trachea and this structure over here pressing onto it. And in this shadow also we see this. And this was the bronchoscopy that we did. Sorry for the not so great quality of pictures, but what we found was that there was, this is the carina, this is the left main bronchus which is fully patent, and this was a big caesium in the main trachea and the right upper lobe. So we removed this and the cough improved and the chest X-ray improved and matter solved. So this was not a child who was not responding because the drug was, the bug was resistant. He was not responding because of a mechanical block. We cleared it and it opened up. So it's not always, if a child is not responding in terms of the respiratory distress, it could simply a mechanical kind of a block. So this is pre and post after bronchoscopy. This is a 7-year-old female. The diagnosis is pretty obvious. I would have loved to see the chat box, but it's not there. A 7-year-old female, 1.5 months history of fever, cough, weight loss, decreased appetite, and contact with TB. And what you see here is miliary kind of a picture. The reticulonodular kind of opacity, which is there throughout in each and every nook and corner of this X-ray. Miliaries are because of hematogenous spread, so you will not have a localized kind of miliary. Miliary means it would be there everywhere, beyond the this also. So a miliary TB is highly suggestive of TB as like a intrathoracic lymph node, and it is because of hematogenous spread. They are a small diffuse nodular opacity, almost miliary-like millet seeds, evenly distributed, and the size lymph nodes can vary. Now the nodules can vary. And over time, if suppose you have got an X-ray done very early, this you can very easily miss it. If you have done a bit late, probably they will all mix up coils and you will have something like this. So this is also miliary. This is not as fine. So a diagnosis in this case would be relatively easier, difficult on that side. So on CT scan, you may better see these nodules, and you may have additionally have ground glass opacities, and with variation in size and distribution and concentration of nodular opacities. And if they thicken, they can. So this is it's miliary on CT scan, where you see these random nodules bilaterally throughout the lung fields. This is an 8-year-old female with 15 days history of fever, cough, distress, mother treated for disseminated TB. And what we see here is you have these reticulonodular shadows throughout, but additionally there is a pneumothorax also. She came with significant distress. So it's when the lung is so much involved, the lung is so stiff that because of this loss of compliance, you can end up having a pneumothorax. So this child had a pneumothorax. We had to put a tube. Now this is a 13-year-old male, again with presumptive TB of 3 weeks history, air entry reduced on the right side, dullness on that side. And what we see here is the pleural effusion or the meniscus sign. So meniscus, the pleural effusion is not what we call as highly suggestive of TB. But a tap can give you some evidence. For example, this had 50 cells, almost all of them lymphocytes. Protein was high, more than this was 5.2. So it's an exudative kind of an effusion with predominantly lymphocytes with this longer history. And if suppose the child has not received injections for very long, so this would fit more into a description of TB than anything else given in our scenario. But you have to make every effort to tap this, send GA, look at those values before you say confirmatory. So you start treatment at the end of 1 month, you see the pleural effusion has reduced. In tuberculosis, many of these lesions, be it the lymph node, be it the effusion, they do not completely disappear very fast. Lymph nodes can persist, can slightly reduce, but they can persist. At times, in a paradoxical increase may be there in a child who is responding. Similarly, with pleural effusions, they take a lot of time to resolve. So we do not always say that they are not responding. So pleural effusion, uncommon finding in children, almost 1.8% in United States, 3.9% in South Africa, more frequent in adolescents and boys, usually unilateral. Bilateral in TB is very unlikely. May be associated with the parenchymal lesion involvement, and the size of lesion can vary from small to very large. And typically they occupy less than 2/3 of the hemithorax. Again, this is a 14-year-old male, received anti-tubercular therapy 3 years back, and the rest of the records were not available. Now, this child was treated with anti-tubercular therapy 3 years back, and this is the radiograph. Okay, there is no chat box question. So what we have here is some opacity on this side. The right angle blunting, we have right lower zone homogeneous opacity, we have highlight lymphadenopathy also here. And this child took anti-tubercular therapy for 9 months. He gained weight. He was feeling better, appetite improved, and then remained well for 3 years. Now he comes to us with chest pain for 2 days and cough for 2 days. And this radiograph, what would you think of? So what we see here is that there is again an opacity still over there. So would you consider it a non-response? The child who took therapy responded well, remained well. Now who comes to you with 2 days history of chest pain and cough and fever with this lesion. So what we thought was that based on radiology alone, we will not, we reviewed history first. And what we found that this was simply some kind of a viral lesion for 2 days, cough coryza for 2-3 days. And the pain was actually a muscular pain. And on weight monitoring, we found there is no weight loss. On temperature charting, we found there was no fever coming up. And we did a ultrasound, it showed pleural thickening. So what we saw, the lesion here was actually a pleural thickening which was lying, which you will always see whenever you get a child X-ray in this child. So there could be residual lesions like this pleural thickening, which do not indicate an active TB. 15-year-old child, again, presumptive TB. And what we have here is, okay, Adolescent, when you say adolescent, it will be reactivation kind of TB, and the site where you see it is this. You have a cavity here, and chronic fibrocavitary lesion because it's a prolonged illness, and you have a parenchymal lesion and a cavity over here. So this is right upper zone, middle zone, non-homogeneous opacity with a thick walled cavity in this case. This cavity is third thing that we said highly suggestive of TB. Turned out to be CB0 positive at the end of 2 months, afebrile for the first 3 weeks, weight gain present, general feeling of well-being. Beginning of ATT, after ATT. So again, if you see at the end of intensive phase, the parenchymal lesion will not disappear completely. And this does not mean that the patient is not responding. This parenchymal lesion, he will heal with fibrosis. And at times, because of healing with fibrosis, you will see that the extent of parenchymal lesion from here to here is shrinking. So it will heal with fibrosis of that part of the lung. So reactivation of post-primary TB, as we just saw, is seen in adolescents and adults. 50 to 90% of the cases result from reactivation of a previously dormant primary infection, which may have self-healed or may have been treated. Parenchymal disease with cavitation, airway involvement, fluid extension can be seen, and they have a predilection for the apical or the posterior segment of the upper lobes or the superior segment of the lower lobes. And the post-primary TB, it could be focal, heterogeneous consolidation, poorly defined nodules, cavities, and tuberculomas. Again, an example of a parenchymal lesion and a thick-walled cavity over here, just to show a close-up of that. Let us talk about tuberculous pneumonia, which means a parenchymal involvement. The parenchymal involvement alone occurs in TB, but it is less common. Alveolar disease varies. It can occur in any lobe of the lung and does not have a predilection to any to the lung apices. The cavitation usually seen in adolescents with reactivation disease, and occasionally in infant also you can have cavitation. So this is progressive primary TB, pulmonary disease, no non-specific imaging finding. So this parenchymal lesion will not always tell you that this is a 3.5-year-old child, subacute meningoencephalitis, raised intracranial tension, and papilledema. So this is right lobar consolidation. You can actually see the horizontal fissure also here. So there is no volume loss, so there is no collapse. It's a lobe which is maintaining its shape and extent. So this is a parenchymal opacity. This child, interestingly, I may not get your answer, but put your hand on your heart and think about it. 13-year-old guy girl referred from psychiatry to us that the child is lethargic and not feeding, appetite is not good, and she has her board exams. So this is and she was referred to us because there was some opacity over here. Any thoughts? So one possibility was, okay, this could be a reactivation kind of TB. You have a lesion over here. Very fine. If you compare this side with this side, you will see the difference. So the radiologist thought that probably it could be a reactivation TB in this apexis. And when we examined the child, there was no history of any fever. There was no history of as such weight loss. There was some lethargy. And the lesion was found out to be this. So it was her hair braid, which was lying here when the child was X-ray was done. You remove this and the opacity gone. In this case, the child, because of the exam, was stressed out, lethargic. So the point is, look at the child holistically. Radiology can help, but in isolation does not. Endobronchial TB, as I said, TB lymph nodes can press, completely press, causing obstruction, partially press, causing hyperinflation, or it can rupture into the airway. That's when we call it endobronchial TB. It may be a complication of a cavitary disease. It represents spread via the airways following caseous necrosis. You can have tree bud appearance. Again, it is not very specific for TB. It can happen in many other infections caused by bronchial wall thickening and filling of bronchioles with fluid, pus, and mucus. And a word about healed intrathoracic diseases.
So, Dr. Kamal, your time is over. So can you summarize within a few minutes?
Yes. So I will finish it up. These are the markers of healed lesion. You can have calcifications which will persist. This again is a calcification. So these are just the calcification that I wanted to show in this particular case. So this is the last slide. This is a child who came to us with received ATT for 5 months and severe abdominal pain with vomiting, with constipation. The child was in a medical ward for 2-3 days and nobody made out what it was. But if you look at the radiograph properly, there was this air fluid level. So when you look at chest x-rays also, look out at these corners also, which can give you a clue that what it is. So thank you very much for the opportunity. Thank you, Dr. Kanaram.
Okay, thank you very much, Dr. Kamal. So I could not see any questions in the chat box. One question is there. Are they not related to radiology? It related to previous talk. Dr. Vendra Singh already covered, but someone asking recent prophylaxis treatments in the pediatric TB.
So we, sir, had just a slide. If suppose there are 3 options, you can have 6H if it is a drug sensitive one. Kerala has an option of 3 months or 12 weeks of HP once a week. In drugs resistant possibilities, if it is fluoroquinolone sensitive, you can give 6 levoflox, 6 months of levoflox. If it is INH monoresistance, then you can use R.
So now I can ask the questions related to radiology. So you mentioned that this mediastinal or Haller nodes are highly suggestive of tuberculosis. So suppose anyone see this X-ray and there are nodes either Haller or this mediastinal node and very difficult to sampling. So can he or she start the ATT based on this imaging?
So again, it will always depend on your capacity to investigate. A very, very high level of center will go on to do a E-bus, maybe a needle from outside CT guided, ultrasound guided. You can try and poke onto that lesion. Depending on your scenario, make an effort, get a GA at least, look for lymph nodes outside the chest. Sometimes what you may see something on an X-ray, but there is a lymph node in the cervical region also. So look for those easily things level, and then give a course of antibiotics. Next 1 week, you can follow with temperature charting and weight monitoring, and send all samples. At the end of 1 week, you should be ready with all the reports, and you have to take a call to. You should not delay antitubercular therapy beyond a point. Maybe 4, 5, 6, 7 days is what you would take. In that time, temperature charting, weight monitoring, all investigations, CB0 would be there, and then you can clinically start if nothing else comes up, despite your best effort.
So in this relation, usually other different diagnoses for either Haller maybe sarcoidosis or mediastinal lymph node, this different diagnosis may be lymphoma and malignancy. So can you summarize some clues that may suggest it may be sarcoidosis or the malignancy, not tuberculosis?
So as I said, radiology is just one part which will tell you that there is lymph node. Why this lymph node is enlarging and reacting? There could be so many reasons for that. One, it may not be lymph node at all. As I said, it could be a bronchogenic cyst. It could be ganglioneuroma. It could be thymus. It could be vascular. So all those things that we are assuming lymph node are not lymph node. Then if you look at other things, what we commonly see, sarcoidosis in pediatric, it is still a very rare diagnosis. What we commonly see is something like lymphoma coming up. And what we see is that he will still, they are not very famished and underweight. They're still relatively, weight is fine, but the lymph nodes are massive. The size at which the lymph nodes increase in malignancy is very, very rapid as compared to TB. For in TB, it will be there for months, not increasing very rapidly. But in malignancy, a very rapidly increasing lymph node, it's what tells you that malignancy. Otherwise, look at anemia, bleeding manifestations for thrombocytopenia. All these things all together will tell you, give you a clue.
So I can summarize that Dr. Kamal's message. One thing, don't see imaging in isolation. So always see the child oral, see the other features they're suggesting. Second thing, please try always to do the microbiological confirmations. If you have the facility like USG guided, CT guided sampling, please go for the sampling. If you don't have the facility, you can refer the centers who have these facilities for E-bus. So because always never try to start the empirical ATT. So every effort should be made to make diagnosis microbiologically. So with these comments, now I can go to the next talk by Dr. Sushant Mane. So he's the associate professor at the JJ Group of Hospital, Mumbai. So and he will discuss regarding this newer diagnosis in tuberculosis, pediatric tuberculosis. So may I request Dr. Sushant to start his talk?
Thank you, Dr. Kanaram. This is visible, right?
Yes, visible. You are audible. You can start.
So this is a good time to take a talk because one, we are running out of time, and second, Varinder sir has already taken most of the contents which my talk is actually focusing on, because my talk was specifically on diagnostics. So, because sir has covered so much about NATs and the cultures, my slides are going to go fast. I'll just focus mainly upon the one or two algorithms what we want to follow, and then skip very rapidly with the slides which are already being done. So when we talk about tuberculosis, okay, when we talk about diagnosing tuberculosis, the basic thing what you must understand is into what stage are we as far as the tuberculosis is concerned. Now, if you see, majority of the cases what we see are in the active TB disease stage, which is the last stage which is seen here, active TB, where we are going to get a patient who is symptomatic. All his immunological tests are going to be positive. Radiology is going to be positive, and also the child is most probably going to get a microbiological confirmation. The problem occurs when we talk about patients of subclinical TB, where especially when we talk about children under 5 years of age, where they would only present with a lymph node disease, the clinical features are not so prominent, so that the patient comes to the clinician with signs and symptoms of disease, where it probably would be picked up if the child is not gaining weight or a slow gain in the weight, on and off fever which is running on, the parents are not happy with the child, you do an X-ray chest and you pick up a node, where the symptoms are not playing a major role, but the radiology is playing a major role. And then comes something known as TB infection, because now we are in the stage of TB elimination, and we are talking about TB infection also, because when we talk about elimination, it is not only the active TB that we must eliminate or we must control, but we must also pick up these patients of TB infection. So what do you mean by infection is the infection of the bug is sitting inside the body. Either they are actively multiplying but not producing symptoms, which is labeled as an incipient TB, or they are not multiplying, they are just dormant but alive, very slow metabolism. So these are the patients which are targeted in TB preventive therapy, and we give this TB preventive therapy to this kind of patients so that they don't go into an active TB. So when we talk about diagnostics, okay, basically we have a clinical diagnosis, we have a microbiological diagnosis, and then we have a other diagnosis. Others is histopathology and radiology. Radiology is being very well covered by Dr. Kamal. So when we talk about the diagnosis, main focus is on the microbiological diagnosis. So we have test which detect active TB, and we have test which detect TB infection. Now, when WHO changed its strategy from stop TB to end TB, they came with a concept of universal DST. This concept, again, what you mean by universal DST is testing all the patients of presumptive cases of tuberculosis, whether they are pulmonary or extrapulmonary. You take the appropriate sample and do the test to pick up the pathogen, and not only to pick up the pathogen, but also resistance to the drugs. Now, initially, the guidelines said that you pick up resistance only to rifampicin, but now since 2019, the definition of universal DST has been changed, that once you get on a clinical specimen resistance to rifampicin, you also have to pick up resistance to quinolones. And this is because all over the world, the quinolone resistance is going up. India reports as high as 42 to 45% of quinolone resistance, which makes this definition of universal DST important. Now, when we talk about tests, okay, as we know, the genotypic tests or the molecular tests which we have, that is the NATs or the LPAs or the sequencing, these are the tests which will not only pick up the bug, but they will also pick up resistance to the common drugs. So that is why these tests are categorized as genotypic test and under the umbrella of drug resistance testing. Now, when we talk about drug susceptibility testing, all our cultures, that is your liquid culture, goes into the umbrella of phenotypic test, where we actually grow the bacilli in the culture, and then we do test the susceptibility to the individual drugs, the first and the second line drugs, and therefore they are labeled as drug susceptibility testing. Now, when we want to classify the test, how are they put forward? Now, first are the molecular NATs. Okay. So if you see, it is decentralized detection of TB, which means these NATs can be run at the district level or the sub-district level, depending upon what is the machinery available. As we have already learned in the previous talks, the experts, that is the CB NATs, require a more advanced laboratory, that is a state biosafety level 3 and 4 lab. So they are put at the civil hospitals and the medical colleges. However, a true NAT is a test which is a battery operated test with less amount of infrastructure required, which can be run also at the sub-center level or also at the sub-district level. Now, when we talk about the centralized DSTs, these are advanced molecular tests, that is your first and second and LPAs, and the liquid cultures, where the samples have to be carried to a drug or DST laboratory or a reference laboratory. Then we have tests for TB infection, which are our skin test and our blood-based test, which are IGRA. And then there are certain newer tests which we will talk about at the end of the talk. So molecular methods, as is being already told, CBNAT will detect MTB. It will also detect resistance to rifampicin. One important thing which was highlighted, I want to highlight here again, is these tests are not utilized for treatment monitoring because it will flag positive even in the case of a dead bacillus. And what you can say, an update over the CBNAT is a CBNAT Ultra, which is more sensitive, especially for us because we deal with pediatric samples which are possibacillary, people living with HIV and extrapulmonary samples. But again, the point of contention here is more sensitive does not necessarily mean a right test. As was discussed, if we get a trace call, then it is a difficult ball game to decide whether the resistance which is picked up by the trace call is a true resistance or not. And then the guidelines say that we have to repeat the test to confirm whether it was a true rifampicin resistance or not, unless and until, the caveat here is unless and until there are definite risk factors to suspect DRTB in that patient. Now, what are these risk factors? There is a close family member in a house who is a confirmed case of DRTB, mother, father, uncle, sibling, or there is a death because of TB inside the house, the child is a relapse case of tuberculosis or a treatment or lost to follow-up child. All these scenarios or situations are considered as risk factors to suspect drug-resistant TB in a child or in a patient. In such a scenario, even if a trace or a very low picks up rifampicin resistance and the patient is clinically symptomatic, culture is going to take time, the repeat test comes negative. Considering all these things, we may start the patient directly on a drug resistant testing. Expert XDR, as was discussed, it is once that CBNAT or a NAT flags that the sample is resistant to rifampicin, then the same sample is run in an XDR cartridge which picks up additional resistance to INH, moxifloxacin, levo, injectables and ethionamide, and then we get the complete resistance pattern. Now, if you see the latest algorithm, in fact, I have not put the algorithm because I thought the treatment portion would be covering the latest algorithm. If you see the latest algorithm, what does the program say, which was released in 2024? When the BPALM came into existence. So initially when the sample is sent for NAT, whether it is a true NAT or CBNAT, once a rifampicin resistance is picked up, the program now is recommending to do an upfront XDR. So initially we used to do cultures if the smear was positive, or wait for the smears. We used to do LPAs if the smear was positive. If the smear was negative, then wait for the culture. If culture came positive, then we did an LPA. Now the program is slowly going to phase out LPAs and keep expert XDR at the top of the diagnostic algorithm. That is because XDR is now validated not only by the ICMR, but it is also undergone approval by DCGI. So as you see, sensitivity is almost similar whether you're using NAT or ultra or TrueNAT. As far as pulmonary TB is concerned, the sensitivity is highly variable when you talk about EPTB. For example, a pleural fluid has a sensitivity as low as 25 to 30%. As compared to that, a CSF would have a sensitivity of somewhere around 88 to 90%. So depending upon the sample what we are sending, the sensitivity differs. Line probasis, as already told, if we do it, if we have lucky enough to get a smear positive, we would be doing a direct LPA on that, and we will get the resistance patterns of the first and second line drugs. If we do not have a smear positive, we will be doing it on a culture isolate if we get lucky enough to get a culture positive. Now again, cultures, now they are the gold standard. So whatever said and done, as far as pediatrics is concerned, the recommendation is always send 2 samples, because even if the first sample comes negative on the NAT, the program guidelines are very clear. The second sample invariably goes for culture, because as compared to the NAT, that is the standard true NAT or a CBNAT, the sensitivity of culture is much more. And therefore, there are instances where the CBNAT comes negative, but the culture will still flag positive. And that is the recommendation why. So, NTEP recognizes 3 key populations. One is people living with HIV. Second is all the extrapulmonary samples, and third is pediatrics. So pediatrics is considered up to the age of 15 years. So in all these 3 key populations, it is recommended that even if the initial molecular test, that is a NAT or a LPA, comes negative, still the sample has to be run for culture mandatorily, because culture can pick up the molecular negative samples, culture can still come positive. The another advantage of culture is very small number of patients we see in pediatric population. This is a problem more in the adult of the NTMs, that is the non-tuberculous mycobacteria. In pediatrics, we generally see in patients who are having predisposing factors like a primary immunodeficiency, secondary immunodeficiency like HIV, or a pulmonologist would see patients of chronic lung diseases, damaged lungs because of cystic fibrosis, PCDs and any other thing. So in these kind of patients, we might sometimes pick up NTMs if a patient of TB not responding to chemotherapy, especially clinically diagnosed, cultures are coming out to be negative, then we ask the lab that, look, this patient is a high risk for NTM, kindly incubate the cultures for a longer time, mount parallel cultures on a solid media, and then the lab will do the needful, and then we'll get an NTM if it is positive or not. Genome sequencing. There is a lot amount of talk about genome sequencing because it is readily available in private labs. In program, it is still being run only at the national reference laboratories in Delhi, Mumbai, and Chennai. Now, it is a very good test. Now, what so there are the variations. So it can be either a whole genome sequencing, where you take the clinical sample and sequence the entire genome and pick up all the mutations, or targeted sequencing. What do you mean by targeted sequencing? Is the machine has predetermined genetic loci or primers which are fed for each drug, and the test will pick up only those targeted loci for drug resistance. Whereas in whole genome sequencing, it will scan the entire 4,000 base pairs of the TB bacilli, and it will pick up not only the known mutations but also the unknown mutations. Now, the problem with genome sequencing is, as yet, we have not been able to achieve correlation between the genotypic and the phenotypic resistance. For example, if genome sequencing picks up resistance to a certain gene for isoniazid or fluoroquinolone, okay, it may not necessarily lead to phenotypic resistance in vitro and in vivo in the patient. So, somewhere there is a discrepancy. Now, this does not happen for all drugs. It does not happen for all the mutations for one particular drug, but still there is a discrepancy, and therefore the catalog of the catalog of genome sequencing results in comparison with the phenotypic DSTs is being prepared at NIRT in Chennai. That is the National Institute of Research in TB. Sooner or later, when we have this catalog ready, which will tell us in our country, in our scenario, which genetic mutations are actually giving rise to phenotypic or actual clinical resistance into the patient, that is a time where we would be using genome sequencing more frequently. At present, if I tell you, the only place where a little the sequencing is used a little more frequently, especially in difficult scenarios, is a CNS TB. That is for CSF. Pyro sequencing is one where we are using it, especially if our initial CBNATs and CBNAT ultras have come negative, culture is coming negative. We started the patient on drug sensitive and the patient is failing on therapy. That is a time where, when we want to repeat test the patient, that probably we would have missed drug resistance in the initial part, especially in a city like Mumbai or Delhi, where we are practicing, where we see a lot amount of drug resistant patients because we have referrals. That is a point of time where we would be sending in a repeat test, we would be sending CSF for pyro sequencing, but again in addition to a phenotypic culture, because culture is important. So it is a very at present, genome sequencing has a very restricted role to play. What tests are available has been already told. NATs are available: TrueNAT, CBNAT, LP, and cultures. And how many samples to send? I have already highlighted 2 samples always when we talk about pediatric patient. Now, when we talk about pulmonary TB, okay, now I know this algorithm people know, but the problem arises is when people do not follow the algorithm. So when we have a presumptive TB case, the first thing is never a microbiological testing. As Kamal rightly said, it is an X-ray chest. Okay, this is the algorithm which is clearly, put forward by the NTEP. If the chest X-ray is highly suggestive, which we just saw, it is a fibrocavitatory, it is a miliary, or it is a lymph node disease, then we take an appropriate sample. If the NAT is positive, we are lucky enough to get a confirmed diagnosis. Depending upon whether it is drug sensitive or drug resistant, we will be starting the treatment. If it is NAT negative, highly suggestive chest X-ray, presumptive TB, we make another attempt to get a sample, properly taken induced sputum, maybe a BAL, or if there is a peripheral lymph node, we will be sampling that lymph node. If it is positive, we are lucky enough. If still it is negative, then we label this child as a clinically diagnosed TB and start treatment. If the X-ray has non-specific shadows, just a consolidation, just a pleural effusion, very short history of around 10 days, not fitting into that 2 weeks criteria, the child has not taken any antibiotics, we would and no history of contact with TB, we would be giving a course of antibiotics, see how the child is improving clinically as well as on radiology. If there are persistent symptoms, we are going to go ahead and do sampling for NAT. And if the X-ray chest is normal, we now know that the patient is fitting into the clinical definition of presumptive TB, but the X-ray chest is normal. Probably we are dealing with a case of extrapulmonary TB, and we would be doing HIV. What is the role of skin test or IGRA as far as active TB diagnosis is concerned? The answer is no, they are not used for diagnosing of active TB. What is the role of ESRs and ADA levels? no role of ESR and ADA because they are not going to tell us whether it is TB or not TB. ADA especially, there is a practice of doing it very rampantly in pleural fluids and ascitic fluids. In pediatrics specifically, it does not help. The game is different in adult pulmonology because there the contention is to differentiate between a tuberculous effusion and a malignant effusion. We in pediatrics do not see so much of pulmonary or pleural malignancies. They are very rare, and our main contention is to differentiate between bacterial and tuberculous pleural effusion, where the ADA levels really do not help us because in both they could be elevated, and culture is mandatory for each patient. Now, these tests were already told. PathoDetect has already cleared the ICMR standards and it is being approved by DCGI. The private labs have started doing it, program yet not taken it because of administrative difficulties and technical difficulties. But yes, it detects both, that is the INH and rifampicin resistance in addition to MTB detection. Now there are certain tests which are written here, that is COBAS. Now COBAS is a technology, it is a German technology which now all the tests which we saw, the NATs, the true NATs, CB NATs, PathoDetect, detects TB with the help of DNA detection. So they will detect a specific locus IS6110, which is specific for MTB. What happens in COBAS is it will detect the rRNA or the ribosomal RNA of tuberculosis. So this is a RNA based test. Again, it is going to detect MTB as well as it is also going to pick up rifampicin or INH resistance. This test is under validation by WHO, still not approved by WHO. Now, as far as samples are concerned, what is new in samples? We already know about stool. Stool is not new. It is approved by WHO. Private labs are very rampantly doing stool samples. Program has not incorporated because of obvious reasons which were explained earlier. Now, there are samples like a mask sample. Now, this study, pilot study, was already done. Dr. Kamal Center and my center, along with 2 other centers, were a part of this ICMR research, and the pilot study had very promising results. So it is a very simple thing. There is a N95 mask which is coated by a nitrocellulose membrane inside the mask. It is the child wears the mask. It is useful for children, smaller children, where we are using a gastric aspirate. The child just wears a mask, and the child is asked to sing a song, talk loudly, or cough, something like that. After 10 minutes, the mask is removed. The nitrocellulose membrane is taken, put in a transport medium. It is taken to the lab. The membrane dissolves once you put it in a reagent, and then TB bacilli is picked up again depending upon an RNA technology. The pilot study, which had around 50 patients, gave a very good sensitivity of around 80 to 82% and a specificity of 70%. We have already completed the large scale community study comprising of 400 children across 2 sites in India, that is Dr. Kamal sites and my site, and we are ready to publish the results now. There are also tongue swabs and buccal swabs which are being tested by ICMR NIRT. The trials are going on. WHO, if you see the latest World TB Day position paper which is released by WHO today and yesterday, it talks about tongue swabs for diagnosis of tuberculosis, where the swab is taken from the posterior aspect of the tongue and an ultra is run on the swab. Urine is one where urinary lamb was already known, but now they are also testing novel methods for picking up DNAs of bacilli in the urine. And blood is being especially evaluated for patients of disseminated tuberculosis, because it is known in the pathogenesis that in patients of disseminated TB, there is a component of bacteria which takes place in these patients. But the problem with blood is it cannot be run on a NAT, because the NAT uses reagents, the reagents which the NAT uses and the system which the NAT uses for the DNA splicing and the DNA amplification, blood acts as an inhibitor for those reagents, and therefore NAT is not a test in which blood is being tested. Blood is being tested for other novel technologies. Now, when we talk about uh, detection for presumptive TB, we are relying upon the classical chest X-ray. Now, what the problem with classical chest X-ray is, sensitivity is poor. That means it is very much observer variable. I may find an X-ray node on an X-ray. A patient who is less experienced may not pick up a lymph node on an X-ray. And that is where the concept of computer-aided detection or artificial intelligence algorithms have come into play. Again, these are approved. These are machine learning algorithms. The names which I have written there, CAD4, TB, and QXR. These are approved by WHO. ICMR India has we have our own study which is being published just 2 months back. The paper is available in the ICMR journal, where pediatric and adult X-rays were collected. Around 40,000 chest X-rays of adults, 20,000 TB and 20,000 non-TB, and around 10 to 15,000 pediatric X-rays were collected. Around 8 to 10,000 TB and 8 to 10,000 non-TB. The machine algorithms are developed in such a way that once an X-ray is uploaded into the software, in a span of around 5 to 7 minutes, the machine tells us whether the X-ray is abnormal or normal and whether it is TB suggestive or not suggestive. So this has already been done by the ICMR, and selected devices have been put across in the selected districts of the country so as to get the ground level data whether these AI algorithms can be used. We are using it in Mumbai at 2 places. Delhi has, UP has, and I think one more state. And depending upon how it is faring into actual community, it might come up into the program where the clinician will take an X-ray chest, take a photo, and it is also available on a mobile app. So he takes the photo and the app will give us a result within no time, whether it is TB or not TB. It is a screening test. Another thing where we talk about follow-up monitoring. Now, sometimes, especially in patients of pot spine or neuro TB, it happens that you do repeated MRIs and it will show a small focus or a lytic lesion which is still present even after 12 to 18 months of therapy. There has been a role of the F18 FDG PET scans, where if you do a PET scan and there is a hot spot which is found, which indicates a metabolically active spot, and if the patient is also having some lesions on the recent MRI, we could say that the disease is still metabolically active. But the caveat here is it lacks specificity. Now, positive spots can come up in any inflammation. For example, in an adult patient, if the patient is having a chronic back pain or a spondylitis or discitis and with a localized inflammation, even that could give a hot spot. So it is very much difficult to distinguish whether it is actually the residual TB or it is because of some other disease. It can come up in malignancies also, and therefore a strong clinical correlation is required. Another important test, new test which has come up for screening of TB. Now, X-ray test was the only test which was used for screening of TB till now. Now we have gone one step ahead. Research has shown that there are certain volatile organic compounds, that is VOCs, which are released in the breath of patients who are having active TB. It could be any compound. It could be alkanes like your ethane and pentane. It could be alcohols like your ethanol, methanol. It could be your benzenes, toluenes. It could be disulfur compounds. All these things. Why do they come up? The metabolism of the TB bacilli is such unique that it will release these compounds into the milieu in which, especially in the lungs when they are multiplying, the host defense mechanisms which come into play, the NADPH oxidase, the free radicals, all these things also lead to release of these compounds, and they can be detected into the breath. Now, in older times, these were, few years back, they were detected by gas chromatography. Now we have handheld machines like a pheno machine where the patient just blows into the machine and you will get an indicator on the machine that whether the VOCs is positive or not positive, and whether it is significantly positive or not. Depending upon that, it is a screening test like an X-ray. We can go ahead and do further more diagnostic test, maybe a CT scan or a microbiological test to diagnose TB. When we talk about monitoring, as we said, we cannot use molecular test for monitoring, and we used to only rely upon smear and DSTs for monitoring. Now they are looking at LAM ELISAs. Now, LAM is a lipoarabinomannan, which is a specific molecule which is present into the cell wall of the TB bacilli. Urinary LAM test, that is your Fuji-LAM, is already being used in HIV positive patients for diagnosis of TB. We cannot use it in non-HIV positive because the sensitivity and the specificity is low in patients whose CD4 counts are very well. But now LAM is being tested by ELISA in the sputum of the patients who are already on anti-TB therapy as a method of detecting the antibodies to this. So if the antibody titers are significantly high, we may conclude that the patient is clinically responding. We may conclude that the patient is responding to therapy. Again, a research tool undergoing validation at the level of WHO. The primary lab has submitted the data to WHO, but not yet approved by WHO. So in summary, so considering all these new tests, old tests, what we are doing actually, I would like to put at the end of the summary. Yeah.
Can you
This is the last slide.
Okay, thank you.
So when we have a pulmonary and an extra pulmonary sample, for a pulmonary sample, we do a NAT with smear. There are 4 possibilities. Okay, either NAT and smear both are positive, NAT is positive, smear is negative, NAT and smear both are negative, and smear is positive, NAT is negative. Now, if we have both positive, if smear is positive, we can do a LPA, and then on the culture, you can do a phenotypic DST. If NAT is positive but smear is negative, then again, we do a culture DST. If the culture is positive, we can do a indirect LPA on that and phenotypic DST. Now, if the NAT and smear both are negative, as I said, because we are a key population, the program still sends the sample for cultures, and depending upon if the culture is positive, we can do further test. Now, this is unlikely to be MTB, NAT negative and smear positive. This is the situation where we would think of NTMs or non-tuberculous mycobacteria, because the NATs which are used for detecting MTB do not detect NTMs. In case of extrapulmonary samples, we are doing NATs whether it is positive or negative, as again, it is a key population, culture will be done. If the culture is positive, our life is easy. We are doing the phenotypic DHT. If the culture is negative, the diagnostic algorithm stops. Sequencing only for research labs, and all of these molecular tests, what you see here, except for sequencing, are available free of cost under the program. So what we are doing right now is this algorithm, what I just showed you. Thank you very much.
Okay, thank you, Dr. Sushant, covering the excellently this new diagnostic test. So I could not see any questions in the chat box. So just because time
Can
is
I,
almost
can I
over.
ask? Can
Yes,
I
sir.
ask a question?
Yes, sir.
Dr. Sushant, Dr.
Yes.
Varinder sir briefly mentioned about the new TB skin test, the
Yes.
TB test.
Yes.
Can you just give us some information about that?
Yeah, so PSI-TB test is a skin test similar to a Mantoux test. So the procedure and everything is similar. The differences being Mantoux was considered positive when the cutoff was 10 millimeters. For PSI-TB, the cutoff is 5 millimeters. That is one difference. Second, the antigens which are used in PSI-TB are the same which are used in IGRA. That is the ISAT6 and the CFP10, and therefore it is very specific only for MTB. For example, if the child has BCG vaccination, he will not get a PSI-TB positive as IGRA was there. So it is a much more specific test for TB as compared to a Mantoux test. And any which was Mantoux, the standard solution is not available, so we are not doing Mantou's. The problem here is right now the program is approved for use and it is being used for adults only 18 years and above. Though the Serum Institute has given the DCGI data for it to be used from 1 year of age onwards. So once the DCGI approval is sanctioned, then program will open it up for children also for 2 years and above. We can start using PSI-TB.
So will it be only restricted to the research level and the RNTCP program model, or will it be available in the private sector also? So
it will be
even
available. It will be available.
private practitioner can do a PSI-TB.
Yeah, it will be available.
And primarily the role would be to detect the latent TB, right?
Latent TB, yes, yes.
So it should be a great advantage for everyone to have a
yes,
detection of
it is a
latent
great
TB.
advantage once it comes up.
Yes,
Yes,
Okay.
yes.
So one question from Dr. Kamal. This
Yes.
is frequently we see that this tree in bud appearance in the CT scan report.
Hmm.
So any relation to the tuberculosis, this tree in bud?
So tree in bud.
Yeah.
Dr. Sushant, should I answer or you'll take?
Yes. Answer.
So it essentially means that there is some fluid which is there in the airway into the till the alveoli. This is what it radiologically means. So by that sense, a cystic fibrosis, when infected, will have this appearance. Aspiration to an extent can also have this. Today itself, we had a patient who actually was having aspirations, but somebody misread it as tree in bud because of TB. So it's a radiological finding. The way we say that lymph node is highly suggestive, chronic fibrocavitary is highly suggestive, but they're not confirmatory. So in that sense, this tree in bud appearance also is maybe there in a consolidation because of tuberculosis, but it will be there because of other causes also.
Yes, absolutely. Yeah.
But in non-specific findings, not necessarily a particular one disease. There are some different diagnoses for the tree in bud appearance. Okay. So Dr. Sushant, I heard some conference this regarding this extracellular vesicles in the macrophages for diagnosis of tuberculosis. So anything going on this research on this
extracellular
vesicles?
Extracellular vesicles where?
In macrophage in blood.
Macrophage in blood.
Yes, yes.
Yeah, so that is what I highlighted a little bit. In those extracellular vesicles in macrophages, what they are trying to do is they're trying to cultivate or culture these macrophages. Okay, and then look at these vesicles, whether they are having TB bacilli or the interferons which are released by multiplying these bacilli. So it is into the phase 2 of research yet. It is still not being tried on humans also. It is a lab-based research which is going on.
But maybe future in we can something
Yeah,
about.
maybe.
So thank you all the three speakers.
Sushant, can I ask one question?
Yes.
Yeah, please.
Last. So can we use XDR as a test on the culture positive specimen? But like LPA, we can use XDR also.
So culture, once the
Suppose
culture is
initially that test was negative, and then you did a culture is positive for like LPA. Instead of LPA, can we use XDR?
So the mechanism for NATs and the mechanism for LPAs is different. Okay. So the culture positive specimen, what we get, okay, it is more viable to be done on an LPA as compared to an expert XDR, because expert XDR would be, it is not said, it is not that we cannot do expert XDR, but whatever what you can say, the company policies or the company algorithm which is being given for NATs, it does not say that you can put, it does not include a culture sample can be run. But yes, because it is DNA, you can definitely run it on an expert XDR and you would get a result. The problem with the thing is LPA would be much cheaper as compared to XDR if we see that on a cost benefit ratio.
Can I just have one comment last in the end?
Yes, yes, sir.
Yeah. Dr. Sushant, now we all found that during the pandemic, COVID pandemic, there were a lot of dormant cases, and after the restrictions were lifted, so many cases actually had a resurgence in that regard. Now, after that, we still have a lot of gap between the detection and the treatment part. So is there any improvement on that scene now? I'm particularly asking you this because you come from Mumbai, which happens to have the maximum incidence of MDR cases.
Yes.
And it happens to be that one of those pockets in Mumbai that probably you have a lot of cases which are otherwise underreported. So is there any improvement on that level now?
So it is very subjective. So the thing is, so improvement has to have two components, improvement on the part of the doctors or the healthcare workers and the patients. So as far as on the part of healthcare workers is concerned, it is definitely an improvement because we are having these trainings. And I always say, I mean, I would be biased. I hope there is no adult person here. Pediatricians are much more aware and much more, sticking to the guidelines, and they want to learn and improvise their practice. So as far as the doctor part is concerned, yes, people are picking up. I'll talk about Mumbai, but in amongst the patients, there is still a lag which is there, and the problem happens is in these pockets, the migration is very high. I mean, every 3 to 4 months or 6 months, there are people coming in into this pocket, staying in those crowded areas, and then they will just keep on going to the local doctors for fever, and by the time they reach actually a place where an X-ray would be done, the minimum delay is at least 1 to 1.5 months, where we say that at 15 days X-ray has to be done.
Understood. Thank you. Yeah.
So thank you very much to all speakers, and we had very good discussions regarding this tuberculosis. So we'll continue to fight this disease, and finally we hope to eliminate in the future. So with these comments, I just refer to this sir, Dr. Jain, Dr. Sanjay Bafna for the.
Thank you, Dr. Kanaram, for being moderator for this session. And I think we have a long way to go, as Dr. Barinder sir also explained, Dr. Sushant and Dr. Kamal for their excellent scientific deliberations. And may I request Dr. Sanjay Bafna to please give a vote of thanks on behalf of IIP Nursing.
Good evening, and thank you everyone. I think we had a fantastic session, right from basics to advanced, and right from diagnosis, radiology to therapeutics. I think it was a wonderful session for all of us, quite a new learning points, and also the revision of the basics. And I would call Dr. Barinder Singh, Dr. Sushant Mane, and Kamal Singhal, they are warrior, TB warriors. I think they are generals, I would say, TB generals, and we are the warriors. And we are there to, IPNRC, of course, and all the pediatricians. I think it is a good session to create an awareness, and I think the fight continues. And of course, I hope in near future we get the elimination done as we did for polio. And thank you each and every one of you, Dr. Barinder Singh, Dr. Sushant Mane, Kamal, and of course Dr. Kanaram Jat, who very well conducted and moderated this session. And for all the participants who attended this 2-hour-long session on TB. I think our interest in TB never dies. Thank you so much.
Yes.
Thank you.
We did not see the Dr. Kamal, just one clarification. We did not see the audience questions because this time the format was changed. And it was basically on the YouTube link. If you see, what we shared with you was a different link, and what we shared in the flyer was a different thing. So most of them were like any other, outside agencies would have their webinars conducted. We have made an attempt. So they all registered there first. And from there, they actually got. So maybe there is a possibility that we will get questions afterwards. We will definitely extend it to you in your private email, and you please reply to them.
I think yes, sir. Yes, sir. I think that there will be option in the YouTube also to put the questions. So
yes, we will do that.
Can pick up the question from there and put here. That may be possible.
Yes, we will tell the tech support team tomorrow to do that. And in fact, if possible, we will relay this session tomorrow on the YouTube, and we will share the recording for those who have missed today's session in live. So probably we'll be relaying it, and we will be sending the recording or our IIP NRC groups. Thank you very
And
much.
website, IPMSC website also.
Yeah.
Okay, thank you, sir. Thank you.
Thank you.
Thank
Good
you.
night.
Thank you so much.
Thank you very
Good
much.
night, everyone. Good night.
Bye.
Thank
Bye.
you.
Thank you.
Thank you, sir.
Thank you.
Thank you so much.
Thank
Good
you.
night.